So the dashboard is something you should be able to audit as well. It would hopefully be public so people would have transparency into the process. And the insurance companies have all sort of felt the same, or at least sung from the same hymnal, that the major limiting factor are doctors' offices' abilities to provide digital data to them. So we also want to keep doctors accountable. What percentage of doctors are actually able to send over a document in a timely fashion so this claim can be adjudicated instantaneously? Chris, you want to take the question about the platform it's going to be on?
Yep. Chris Klomp, Director of Medicare for CMS. Industry has pledged to provide metrics along several key dimensions, including numbers of percentages of code reductions requiring prior authorization, as well as adherence to defined standards around timeliness and transparency of that process, as well as adoption of electronic prior authorization standards that are being rolled out as part of the regular rulemaking process by CMS, both for medical procedures and for pharmaceutical procedures. Those should be available on the AHIP website. We intend to publish those as well ourselves at CMS.
Dr. Oz, you mentioned you'd like to see a lot of services no longer subject to prior auth. Can you give us a list of what your top 5 would be, and has the industry agreed to any of these yet?
The industry wants to reduce the number of procedures. Let me give you some numbers, and I'll ask Chris to brainstorm on 5 ones that you think are particularly egregious, if you want. There are about 15,000 procedures generally that could be candidates for pre-auth. About 15,000 procedures generally. There's about 6,000 that get pre-auth, but they're not the same ones for every insurance company. So there's probably 2,000 or 3,000 really core events that you probably want to have pre-authorization for, also for the betterment of patients to make sure these procedures are done correctly. Knee arthroplasty, or arthroscopy as an example. So is the right patient getting it at the right time by the right physician for the right indication? And so if the insurance companies can narrow down the scope of the pre-authorization requirements to really address the ones that are most likely to be abused, it'll make the whole process more seamless. And they've argued actually that similar to what e-prescribe did, you create a set of standards and all of a sudden you can do electronic prescriptions. They think once they get this standardization process for pre-authorization, it would open the door for many other types of administrative burden reduction as well. Chris, 5 ideas you might have.
I'll give you a few. Colonoscopy, cataract surgery, 2-day stay, vaginal delivery, things that are pretty common that are less likely to be abused. I think the bigger point and what we're more focused on is the process and the principles by which appropriate care is determined. Let me give you an example. Take a given episode of care that might require 2 different imaging studies as well as 3 different diagnostic lab studies all in sequence. Status quo today for many insurers is that each one of those separate components will individually be prior authorized. That's illogical. We know what the episode of care is. That episode of care arguably wouldn't require and shouldn't require prior authorization at all, but if it does, it should be done once, it should be done quickly, it should be done almost invisibly to the patient. And then the patient and the provider should be left to go about delivering care and the business of healing.
I'll add one other thing, is that there are 6 commitments that the insurers have made to us during our meeting today. And one of those is interoperability, and this is very critical because right now each insurer has different rules for compliance. Some of them demand correspondence by fax. Some of them have their own portals on the internet where you upload the data, upload the patient's records. Other ones require a conversation by telephone. And so every time a doctor has to, or a doctor's office has to go through this process, they're facing this kind of Byzantine collection of procedures that they may not know for that particular insurance company. And if they do it wrong, if they correspond by fax, they get denied. And so these companies have now agreed to unify their protocols so that all of them will communicate in the same way and to standardize the process. And that's going to dramatically change the patient experience.
Secretary Kennedy, if I could just give you one example. Chris mentioned vaginal deliveries. Yes, we have to prior authorize vaginal deliveries. And whether the insurance company said we could deliver the baby or not, we went ahead. But to your point, every other week, one of my nurses would spend the better part of the day going through authorization processes for the deliveries upcoming in the next couple of months. And it becomes this ping pong delay game and just the hassle factor. So rather than my nurse taking a blood pressure on one more patient that's sitting there with swelling and abdominal pain, trying to figure out they have preeclampsia or not, instead she's in the side room working on pre-authorization. So this is, as Dr. Murphy mentioned, it's an everyday hassle factor for us.
I'll just say one thing. I think one thing that we know today is a different age. Artificial intelligence should help this tremendously, and it should take out a lot of the variances that happen between doctors, hospitals, regions of the country, et cetera. But remember, artificial intelligence only is as good as what you put into it. So if your artificial intelligence, as some has already had happen, puts into a key to deny on basic tenets, then the denial rate's going to be the same. So I think this is another proof in the pudding that we're going to have to see, are these people actually putting into the AI things that are reasonable, things that are medically necessary, so that what's spit out is reasonable for the patient, most important for the patient, and reasonable for those who provide the care.
Hi there, Rachel Korzing with Bloomberg. It seems like you're leaving the door open to regulating here, and I was wondering if you could offer any color about what would lead you to believe that it would be necessary to regulate? Like, at what point do you decide enough is enough, like it's time to move forward with regulation here?
Was as high as the numbers that we quoted for the insurance executives that we just met with upstairs, 257 million Americans, that's not all the Americans. So we still have about 25% of Americans whose insurance companies were not represented in the meeting today. During the meeting, another one joined, but they're not all there, and until they're all there, we're going to keep pushing and shoving. And even the people who are already in the room agree that there's a possibility you may have to help nudge people, herd people, so you'll make the right decisions in a timely fashion. But what Secretary Kennedy outlined is really critical. If we address the interoperability challenges of the industry, it actually helps them do what they probably want to do already. The beautiful thing about this pre-authorization process is, in discussions with these insurance executives in private, they all sort of want to do it. They just couldn't do it that easily. So using the ability of government, and under President Trump's leadership and Secretary Kennedy's passionate desire to address this, we made it clear that we're going to do this one way or the other. We're going to open doors to make it easier for you to do it yourselves without us getting involved. Please build the nimble, industry-friendly system that takes care of the American people. That's the challenge. And it doesn't work the way that we intend, as was outlined earlier. We did trust but verify.
Thank you. Do you guys think that you're going to pursue legislation or regulation to codify this, or this even if the insurance companies are willing to comply and be meek right now?
Absolutely. We've been working on this. Greg's been working on this for years now, and I think that we're very close. We've got the score, the CBO score down on it, and I do think that we owe it to our patients to go ahead and codify something.
Hi, Adair Tuchin, Real Clear Politics. And then I'm just wondering, since these are voluntary reforms, what incentives will HHS provide to ensure insurers actually comply and follow through? And then if not, what recourse will patients have if delays or denials persist?
This is a very fast-moving process. We anticipate having in place rules that will protect patients, I should say rules, the industry having rules for themselves in place by the end of this calendar year. So 7 months from now, you're already going to be benefiting from these decisions if you're a patient. We are confident that some companies will come along, others might not. We have the ability through the rules process to enforce pre-authorization if necessary. It is a process that is necessarily limited by a series of steps that's there to protect all Americans. In this case, unfortunately, it's going to slow down the implementation of pre-authorization. That stated, I am optimistic, hopeful that we don't have to do that, but it's always in our back pocket if we need it. Thank you.
James Eustace with Real Clear Politics. What are some specific metrics and deliverables that you're looking for from health insurance companies?
We'd like to see meaningful reductions in code counts requiring prior authorization, including several of the obvious ones that we've talked about. A vaginal delivery, why is that a question mark in this day and age? You're shaking your head. I do too. I think most insurers do as well. there's opportunity to eliminate that. That's actually not the set of metrics I think are most compelling and will be most felt by individual patients. It's the faxes and the phone calls that providers experience, where they then experience uncertainty, often at that moment, as was talked about by Dr. Oz and Secretary Kennedy and Eric, when they feel the greatest level of uncertainty, but also a despondence and despair and desire for knowledge and certainty and action, and they can't get it. So I am most focused, I think we are most focused on the set of metrics related to the process. One of the goals is that by 1/1/27, at least 80% of all prior authorization requirements will be adjudicated in real time at the point of care. That's a meaningful change in behavior. You're sitting with your provider, they're telling you the test that they want to order or the treatment plan that they'd like to issue. They put it into their EMR or their other software program through FHIR-based standards that CMS has identified and promulgated throughout the system, and immediately let you know where you are. And in the event that there isn't an approval, you have a transparent, clear timeline that you can hold your accountable or your insurance company accountable for, so that you can gain clarity, and that doesn't need to add to the burden of uncertainty. Those are the metrics that we care about. That's the patient experience, the beneficiary experience that we're focused on. This is why the Secretary made this such a high priority early in the administration. What percentage are we of real-time same-day adjudication? Low single digits. Yeah, it's a little bit complicated you have to break down medical versus pharmacy, but it's low, and from a patient's perspective, exceptionally low. More than 50% of all prior authorizations are still paper-based using phones and faxes. So you can imagine the timeliness of that.
We have our last question right there. Hi, Chelsea Ceruso with Stat News. Dr. Oz, insurers made a similar pledge in 2018 that wasn't quite lived up to. What's different this time around?
Secretary Kennedy alluded to that. There was another effort in 2023. I think two things have changed. There's violence in the streets over these issues. This is not something that is a passively accepted reality anymore. Americans are upset about it. Secretary Kennedy made it very clear from the outset that we're going to deal with this issue one way or the other. We have legislation pending that would come in as well to codify some of these changes. But I think the major factor is the industry realizes that some of the things that are pre-authorized just don't make any sense. And they now believe that because we could actually create an interoperable digital system of connectivity with very agreed-on standards, this actually could become a real-time process, which takes a lot of money out of the system. They estimated earlier today that it costs between $35 and $45 per documentation of pre-authorization for the doctor's office. It costs the same amount for the insurance company for every single time. And there were 3.2 million documents last year for just Medicare Advantage. So multiply the numbers and you begin to realize we're throwing money away on administrative costs just financially. We're also wasting people's times. And we have the technology today to actually address this in a meaningful fashion. But the most important reality is the administration has made it clear we're not going to tolerate it anymore. So either you fix it or we're going to fix it. And I think they wisely have decided that they should fix it. I'm looking forward to seeing the results. Secretary Kennedy, thank you for giving us an opportunity.
Thank you all. Thank you all. And I will add one